make an intermittent squint to a manifest squint. Okay. So always sensor evaluation first before your motor evaluation, because sometimes what happens is your fusion will be keeping your intermittent squint. No, so if you keep on doing your cover test and all, you will make an intermittent squint to a manifest squint, and you will get a different interpretation. Okay. So this is I think all of you know this, Bagolini striated glasses. These are striated glasses which are placed obliquely. That is, at one eye it is 45 degree and other eye it is 135 degree. And we show a pen torch. And the patient is asked to report what he or she sees. So what happens in a normal bifoveal binocular single vision, we will see a cross, like first picture. And if you have one eye suppression, you will see only one line, like the last one, either the right or the left, which depending upon which eye is suppressed. Then if you have an esotropia, you will get a V pattern. And if you have an exotropia, you will get an A pattern, A. And if you have a central scotoma, like in a monofixation syndrome, central scotoma, you will get a cross with a gap in the center. If you have paracentral area, there is a gap. So this is how you do a Bagolini striated glasses. Okay. I hope all of you know this. So we'll go into the next slide. So after that comes your stereopsis. Ideally, we should do stereopsis for distance as well as near. But most of our clinics don't have distance stereopsis. So in exams, I don't think they will ask for distance stereopsis. So, but you should know about near stereopsis. Okay, one of you please tell me what test is this, and what is how do you do this?
It's a titmus fly test.
Yeah, titmus fly test. Yes.
And we give this a specialized glass, polarized glass.
Yes, Polaroid glasses. Yes, Polaroid glasses. And we ask the child to see which image is popping out from the book. Okay, so you have a fly, then you have animals and circles. So for, like that, you can quantify the amount of near stereopsis. Okay. So you have another test for near stereopsis. This is which test? That was titmus fly. Then this is
TNO, ma'am.
TNO test. So here we use red-green glasses instead of Polaroid glasses. Okay, good. So now coming to Worth-Fodor test. So as you all know, when Worth-Fodor is, we keep a red glass in front of the right and green in front of the left. Okay, then you show the torch with these 4 lights, and you ask the patient what he or she sees. This should be done for distance as well as near, both. Okay. So normally a person sees like this BSV. So you'll get a 2 green, 1 red, and 1 yellow or white, whatever. Then if you have a left suppression, you will see only red. If you have a right suppression, you will see only green. And you have a double vision, you will see 5 circles. I hope till now all of you understood, no?
Yes.
Okay. So now we'll move on to the next evaluation, that is motor evaluation. So motor evaluation, you have cover tests, versions, ductions, and versions. So one of you please unmute and tell me what are the cover tests and what are you inferring from the cover tests. And before that, I'll just tell you about the prerequisites. So if you have to do a cover test, the patient, there should be an accommodative target. You cannot just show it a pen torch and do the cover test. You should have an accommodative target for distance as well as near. So you can take these types of age appropriate vision charts or finger puppets or near vision sticks and all for fixation. And the child should wear proper correction in place. Whichever glass he or she is wearing, they should wear, and they should have a fixational and fusional versions. Okay, now, so any one of you, please, cover test.
So in cover test, we should cover one eye first.
No, tell me what are the cover tests?
Cover test is cover, uncover, and alternate cover test. 3 tests.
Yeah, cover test, cover, uncover test, and alternate cover test. Yeah, cover test. First, direct cover test.
Directly cover test. When you cover one eye, we will see the movement of other eye, which is not covered. So it will show.
So how do you know which eye to be covered?
I I will cover the
Normal eye.
Fixating.
Fixating eye.
fixating eye. Yeah.
If both are looking like same, so then which will you cover?
Then I will cover the
Right.
right one. Right one.
So you can say tell apparently fixing eye. You don't know which eye is fixing. If you so you cannot just tell like that. So you will be looking at you will be covering the apparently fixing eye and looking at the movement of the
Other
other
eye.
eye. So cover test is always other eye. Okay.
Yes.
Okay. Then
And gives
uncover
us
test.
tropia. It
Yes,
helps us.
tropia.
And after that, I will uncover the eye, which has been covered. That I will see the movement of the uncovered eye.
Yeah,
Of
while
the eye.
uncovering, or if you are using a speed band occluder, you can see the eye undercover also. Okay.
Yes,
So we
yes,
should
yes.
both eyes consecutively. Cover first both eyes, then uncover both eyes like this.
So you during cover test, you are covering one eye, apparently normal eye and looking at the movement of the other eye. During uncover test, you are uncovering the eye and looking at the movement of the eye undercover. Okay.
Yes.
Then alternate cover test, you are doing alternate cover test, then you will be getting both tropia as well as phoria.
Ma'am,
In the cover,
in uncover test, we will seeing the phoria, no, ma'am?
yes, phoria. Direct cover test tropia and cover uncover test phoria, alternate cover test tropia plus phoria.
Yes, ma'am.
And one thing you should remember, when you cover and uncover that test you do, you should never move the cover from one eye to the other across the eye. You should move it like in between. You have to, the patient has to fuse. You should not break the fusion while doing cover test or cover uncover test. Only in alternate cover test, you can move across the eye. There you are breaking the fusion. You want to know both tropia as well as phoria. In the other test, you don't want to break the fusion. You want the patient to get a fuse in between. Okay.
Okay.
Okay, I'll just show you some videos. 1 minute. So direct cover test,
Ma'am, this
here you
point is not clear to me. Excuse me, ma'am, this point is not clear to me.
what?
How to unbreak, how do we do the test when we don't want to unbreak the fusion?
Yeah, that's what. See, if you see, just think the patient is having right eye exotropia, left eye is fixing eye. So you cover the left eye, then you move the cover down. You should not just, means from one eye to the other, you should not move. So you should keep just some point in between so that the patient fuses. So if it is an intermittent X-ray, the patient might fuse in between. Okay.
Yeah.
I hope I have a video. I'll show you just 1 minute. So cover test, you have direct cover test that tests your manifest deviation or the tropia. Then you have the uncover test that is for latent deviation or the phoria. And you have the alternate cover test that's for both manifest and latent deviation. Okay. So first this one, see. So when here this left eye is the apparently fixing eye. So I am covering the left eye and now looking at the movement of the right eye. So what you see?
There is fixation movement from inside to outward in the right eye.
Yeah. So what is that? So what you see that? So what is the diagnosis there?
Mr. Right
Here-
eye esotropia.
Esotropia. Yeah, there is tropia only. So you are seeing the tropia and just see this image. One more time. Yes.
Left
Okay.
eye exotropia.
Yeah. So here you are covering which. So this is the apparently fixing eye. This is the apparently fixing eye. So you cover that eye and look at the movement of the other eye. So if it is going out, it is ESO. If it is going in, coming in, it is EXO. Isn't it?
Yeah.
If it is going up, it is hypo. If it is coming down, it is hyper. It's very simple. Okay. So now you see this patient. So I'll play the first. Someone please tell me. Okay, tell me.
The left eye under cover is going is moving inwards.
Yeah. So
So it's a phoria, I think, esophoria
esophoria.
of the
Yeah.
left eye. Left eye.
So so since I am using this Spielman's occluder, we can see undercover from through this occluder only. If you are using this one, it will actually it is difficult. When you just uncovering, you have to see the movement. Here it's very easy. So you can just see the eye undercover going in. So it's a esophoria. Okay. Okay. So in this patient also, the second image you can see when this child was looking straight. So when I covered, you can see the eye is moving out. Can you?
Moving in, ma'am.
Moving
Moving
out,
out.
undercover. Second
Ma'am,
image.
So
oh,
it's
second image, not
exophoria.
been played. Oh, okay. Oh, yeah. Moving out.
That is not
Yeah, yeah.
a video. That's just an image.
Okay. Yeah. Moving
So you
out.
can see. So this is exophoria. Okay.
Is Hirschberg's reflex compulsory, ma'am? Like, I have little.
Hirschberg reflex. You have to just mention because it is. I'll come to that. I'm just
Oh, you're
talking about
using a light
Hirschberg's
reflex
also.
here, but normally we will
Hmm?
for this cover and cover test. You just need to not obstruct the view, like, and then put the cover and remove the cover to see the movements. No, ma'am. But here is the reflex. You have put to use a corneal reflex also. Is that aspect required?
Yeah, corner. Yeah, you have to tell about Hirschberg's reflex. I will come to that later. How do you interpret Hirschberg's reflex? I'll tell you. Okay. So, okay. Now, just see this. This is alternate cover test. Okay. So, see, I am not allowing the child to fuse in between. I am just moving across the eye. So, in between the child is not, I mean, at any point of time, the child is not using the eye, both eyes at a time. So, I am breaking the fusion in this case, alternate cover test. Understood, no? Otherwise, I will move from this and this. So, in between, the child will use both eyes
Yes, clear
for
now.
direct and uncover test.
Thank you, ma'am.
Okay. Now, just observe these two cases. I'll play the first image. Let's see. Okay. Now, just the second one. Sorry. Okay. Yes, please. What do we see?
Insect.
What? You want me to play again?
Yes, can you please play again, ma'am?
Eye undercover is moving outward, non-removal
Yes,
of the occluder,
exactly.
refixation possible. It's a case of exophoria.
So you think it is it's actually it's an exophoria. So this is very important because this here, when I cover, see first, so when I cover, it's going out, isn't it? See, the eye undercover is going out. But when I take, what happens is it slowly comes in and takes a fixation. It's not like an exophoria. In exophoria, the eye will just come and take a fixation. Okay, this is slowly coming. In this case, when I cover, you just see it's going out. But when I take the cover out, the eye just the girl just blinks and it becomes central, isn't it? So here, what happens is it's an extension of your phoria, where your fusional reflex becomes poorer. So when you cover the eye, it goes out, but when you uncover, it will not come immediately as in phoria. It will take some time or with a blink and then takes up the fixation. So here, intermittent divergent squint. Most of this, when you means your clinic, you must have seen patients saying whenever they daydream or whenever the child wakes up, the eye is out, but in between she is fine. So this is a typical intermittent divergent squint. It usually starts for distance. When you take a photo or something, you will see the this one squint. But when you ask the patient to just be alert, then the child awake, it's okay, everything is fine. So it usually starts for distance first, then it comes to near, then it becomes constant. So there are different grades of intermittent divergence that you need not know, but you should know that when the fusional reflex becomes poorer, the exophoria goes into intermittent divergence squint and later into constant deviation. Understood?
Ma'am, you want to say in Fourier, the reflexation movement will be slow?
Fast. Phoria,
Fast.
it will exophoria means it will when you uncover, it will immediately come and take a fixation. But in IDS, it will come slowly only.
Actually, I think if it's come within the blink of after eye, then it's there is exophoria, but it's coming after slowly after things, then it's an intermediate. And after some time, it's
No,
become exotropia.
So I think they,
Ma'am,
yeah.
because
the
vision is compromised in the left video. That's why it is taking off slowly.
What? I didn't get it.
Because refixation movement, slow refixation movement, is it because of visual compromise?
No. It's not because she is excited. No, it's not because of because in IDS there are a few stages. In the first stage, there are some NCS scoring and all. Newcastle score. This is Newcastle score. In the first stage, there will be slow movement. In the second fair control stage, what happens? The child blinks and then it becomes central. In the third stage, even if the child blinks, it will not come to center. It will take a lot of time and then only it will come to center. So there are 3 stages: good control stage, fair control stage, and poor control stage. In the good control stage, it comes slowly but without blink. Second, fair control stage, it comes but with a blink. Third, it will not come even if the patient blinks. But in between, the patient is ortho also. So that is the different stages. But I don't think they will ask about that. But you should know at least this name, Newcastle score.
Ma'am, left picture has been clearly understood, but the right one, no, sorry, the left one, right is okay. The left one undercover, it is
Going out.
Going out or hypertrophic?
Out. See, you can
Out.
see the image. The eye is going out, no?
Okay. Yeah.
Okay. Ma'am, I need to ask if we have to do cover and cover with and without glasses, only with glasses, if the patient has glasses.
If the patient has glasses, with glasses also, without glasses also, but with glasses, if the patient has glasses, with glasses is 100% it's needed. So because usually because if the patient is not seeing, most of the myopic patients are exophoric, no? So you should ask the patient to wear the glasses and then do the cover test. But you can do cover means with glasses and without glasses also if the patient is able to fixate.
Okay.
But in exam to find out what the squint is, it's always better to without glasses, ma'am, and near distance and then with glasses, ma'am. So you can find out exactly what the underlying pathology.
Yeah, you should do both with and without glasses.
And should we do like for distance and near both?
Yeah. First for distance, then for near. Okay. Okay. Now come to the next important part, that is ocular motility. Because many of these exam previous papers, I saw many people, they ask for ocular motility in many previous past experiences. So you have ocular motility, versions, ductions, and vergence. So versions are your binocular conjugate movement. Like when you go look to the right, look to the left, look up, like that, versions. Ductions means when you are looking only at one eye, uniocular movements. And vergences are binocular disjugate movements. So it's like either a convergence or a divergence. It's in different directions. Okay. So how will do a version? So with both eyes open and are done first before testing duction. So you should do always versions first, then only ductions. And you should move the target in the 9 gaze positions. What are the 9 gaze positions? Your primary position, then your up and down, then up right and left, then down right and left. These are your 9 cardinal gaze positions. Okay. So actually, while we are doing these extraocular movements, we are also doing the pursuits. It's a slow movement, no? So if you want to complete saccades with that, you can also do saccades. Saccades, you just ask the patient to look to Sorry, I think my voice is also coming, so it's okay. So ask the patient to fix between targets right and left, and also up and down you should do. So that is your second. I hope all of you know this versions. Okay. So, so can anyone tell which all muscles act in different gazes?
Yeah.
One I have already written. Yes, please,
Right,
Gayatri.
right side, when we look right, lateral rectus and left medial rectus.
Okay, very good. Right lateral rectus and left medial rectus. Okay, then
And
left.
left, right. Left lateral rectus.
Very good. Next, someone else, please. Right up. That is dextro version. Dextro elevation.
Dextro elevation, it will be right superior rectus and left this one right superior rectus and left inferior oblique. And for dextro depression, it will be right inferior dextro lever elevation will be right inferior oblique and left superior rectus.
Other one, right
Inferior rectus and superior oblique, and for that one it will be left inferior right inferior rectus, right inferior oblique and left superior rectus.
Okay, good. So I hope all of you know, because the muscle axis and the orbital axis, when it comes means parallel, then there will be maximum elevation action of recti. So recti will be having maximum elevation in abducted position, and oblique will be having maximum elevation or depression in the adducted position. Okay. So this is this adducted position that we will look for the oblique overaction, because obliques are pure elevators or pure depressors in the adducted position. So we will look for the oblique overaction in this adducted position. Understood, no?
Yes.
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 Okay. So there are few there are few laws governing the ocular movements. As you all know, Herring's law. Herring's law is for movements of both eyes in the same direction, the corresponding agonist. Like when you are going to the right side, your right lateral rectus and left medial rectus. Okay. Then you have Sherrington's law, where there is reciprocal innervation of antagonist muscles. So what happens in the right gaze, the right lateral rectus will be acting and there will be relaxation of the right medial rectus. So antagonist will be relaxing. What? Any question? Okay. Okay. And as I told earlier, when your yoke muscles, the muscles which act in the same at the same time, like right lateral rectus and left medial rectus are your yoke muscles. Like that, right superior rectus and left inferior oblique are your yoke muscles. So muscles which act at the same time during one particular gaze. So what you see? Anyone, please?
Is a right inferior oblique overaction.
Yeah, actually both sides are the picture is taken slightly. Actually, there is bilateral inferior oblique. So you can see when the child is looking to left side or right side, the other eye, the adducting eye is going up. So there is inferior oblique overaction, bilateral inferior oblique overaction. Okay.
Ma'am, this will be usually elicited in versions, no, ma'am. Dextral
yeah,
version.
versions.
Yeah. But it will be more clearly elevated in dextral elevation and lever.
Yes. Okay. So coming to the patterns. So what all patterns you know? There are many patterns, but mainly for exam purpose, we have mainly
A and B
A and B patterns. So how will you examine a patient for patterns?
We measure the Hirschberg in the primary position, then while looking upward and down. And
Hirschberg is always in the central. You cannot see, ask the patient to look up and do Hirschbergs. But what you have to tell is you need to see the squint in the up gaze and down gaze. So this you can even either ask the patient to look down, then center, then up. or you can only tilt the head up and down. So when you ask the patient to head down, what happens is eye goes up, your up gaze will be down. If you ask the patient to look down, the eyes will be in the up gaze. When you ask the patient to look up, like not look up, head up, then the eyes will be down. So you can either do by asking the patient to move his or her eyes, or by tilting the head. Okay. So see this video and tell me what is there. Okay. Tell
V
me.
pattern.
V pattern
Yes.
exotropia.
V pattern XT.
Yes, there is primary, there is an exotropia, but it decreases in the down gaze, but increases in the up gaze. There is a V pattern exotropia. So if you encounter a V pattern exotropia, then next thing what you should look for, where you will get a V pattern exotropia,
Inferior
which
oblique.
muscle overaction?
Or inferior oblique.
Inferior
Oblique
oblique
overaction. Then you look
overaction and
for
superior
inferior
oblique
oblique
control.
overaction. Okay. So like this child, you can see XT, but it is more in the up gaze. So V pattern, when you actually, when the patient is looking from a 25-degree up gaze to down gaze, there will be more than 15 PD. This is more important. In V pattern, it is more than 15 PD. For A pattern, it is more than 10 PD difference. So just if you are getting 30 here, 35 here, and 30 here, it's not V pattern. There should be a difference from the up gaze to down gaze of about 15 PD or more. Okay. So if there is a V pattern, then you should ask the patient to look. See, you can see there is inferior oblique overaction here. Can you see that?
Yes,
Yes.
you can see.
So this is a V pattern exotropia with inferior oblique overaction. Why it is important? Because your management differs. If the patient is having exotropia with inferior oblique overaction, you will do lateral rectus recession, and along with that, you will handle the oblique recession, inferior oblique recession also we will do. But if the patient is not having an inferior oblique overaction, but still the patient is having a V pattern exotropia or esotropia, you will upshift or downshift your muscles to treat the V pattern in those cases if there is no inferior oblique overaction. Understood?
Ma'am, one thing.
Yeah.
In the treatment, in the pattern for correction, it has been written only like that, recession or resection with transposition and up and down. So,
No.
what you said in second part, but
See,
inferior
if the patient is having exo or eso with a definite inferior oblique or superior oblique overaction, you have to tackle that oblique. But
okay,
if
then
the
no
patient is
need to
having
transposition.
no means you can, but that it's actually it's not required. But if after you do all these and then again if it is there, you can actually say as a secondary procedure, but primarily no. If there is inferior oblique overaction or superior oblique overaction, you have to tackle that thing. Then if the patient is having exo or eso without inferior oblique overaction, then you have to upshift or downshift the muscle to correct the V pattern. Okay.
Madam, how to measure the deviation in up gaze or down gaze?
Yeah, that's what I told. No, you ask the patient to you just tilt the head down, then the eye will be up. Then you ask the patient to read the chart and make a your PBCT you will do prism bar cover test.
Prism bar.
So you can measure until you get a neutral point.
Ma'am, here
No,
there is no issue of distant and near object. No issue like that. No.
Distant, only distant. For a pattern, only distance, not for near.
Okay.
Okay, only for distance. Okay. So this is like another pattern, that is where there will be superior oblique overaction. This is A pattern. So you have to know V pattern is for inferior oblique overaction and A pattern is for superior oblique overaction. But you just read this line. There is more than 10 PD. The other one was 15 PD. So here, if it is 20, if it is 15, at least 10 is enough for A pattern. But other one is 15 PD. Okay. For A pattern it is 15 PD, 10 PD, and V pattern it is 10 PD, 15 PD, sorry. Okay. Now coming to versions. Versions, how will you do? You just close one eye.
Ma'am,
Oh,
ma'am,
yeah.
one question more.
Yeah.
You said no that A pattern superior oblique overreaction and B pattern inferior overreaction.
Yeah.
It will not always be present, no, ma'am. I have
That's
to
what
check
I'm telling. If it is not present, then you cannot tackle your oblique, right? Then you have to
Yeah.
follow that male. Have you heard of male? Medial rectus to the apex and lateral rectus to the base. You have to
Yeah,
shift
yeah,
it. Yeah.
yeah.
Okay. So that is why you should know whether there is an oblique overaction is there or not.
61.
I
Yeah,
hope
yeah.
you understood.
Yeah.
What is male?
Understood, no?
Yes, ma'am.
Yes,
Okay.
yes.
Yes, ma'am. Yes.
Dr.
Yes.
Remya, could you explain what is male again?
If the patient is having a V pattern exotropia, but when I'm doing the extraocular movements, there is no oblique overaction. So what I do is when I see if I am doing a LR resection with MR resection, so I will move my medial rectus to the V pattern. The V apex is down, no? So medial rectus I will downshift and lateral rectus I will upshift. Male means medial rectus, apex, lateral rectus, base. I'm not medial rectus, apex. You should know. So then you know if where is the apex? Down, right. So you should downshift the medial rectus. L lateral rectus, it should upshift.
This is only for pattern deviations, or
Yes,
it can be
pattern.
All right. Yeah. Thank you.
Okay.
What if we don't correct, ma'am? What if we don't upshift and downshift? What will happen then?
Yeah, the patient, because these V patterns and A patterns, no, the child will be having a head posture. Okay, so you see, if the patient is having a V pattern, your exotropia is very less in the down gaze, isn't it? So the child will be having a chin up position, so as to keep his BSV means get his squint less in that gaze. So if you don't correct this one, the child will be still having a head posture. You are
If-
not correcting your pattern, no?
A
Okay,
pattern,
ma'am. Is
A
there any?
pattern have reading problems also. A pattern
What?
reading problems with A pattern exotropia. Child cannot read properly.
Yeah, there will be because you are not correcting your squint fully. The child will because there will be an actually A pattern and V pattern are incomitants. What we normally comitant squint is where your deviation will be equal in all 9 gaze positions. That is what comitant, no? Comitant ET, comitant XT means wherever you measure this amount of deviation, that should be equal in all gazes. But actually A pattern and V pattern are an incomitants in your comitant deviation, because of this oblique overaction or whatever thing. So you have to correct the incompetency also in that case.
Ma'am, there will be a V and A pattern esotropia, na?
Yeah,
Yes.
there can be.
Okay.
Okay.
So for that, even this male formula applies.
But most of these cases will be having oblique overaction. But if it is not there, then this is the method. That's what just I told.
Male for both ESO and EXO.
Yeah. Oh, same mnemonic.
Okay. Thank you.
And for versions, we check uniocular for one eye, but versions is both eyes we check together, right?
What?
Versions is for each eye we check the extraocular movements.
Ductions.
Versions.
Versions binocular, both eyes open.
Okay.
Vergence also both eyes open. You cannot say convergence is for both eyes, right? You cannot do single convergence, one eye closed convergence. So versions and vergence are binocular, whereas duction is only monocular. But if your version is normal, your duction is always normal. Okay. But if your version is abnormal, you can still have that I will come. Okay, I'll tell you. So versions, what you do, you ask the patient to look in different directions of gaze, with one eye closed. Okay. So why the importance doing duction second and versions first? Because just think about this condition. If you are doing a version, you are getting your right inferior oblique overaction. Just think that scenario. Right inferior oblique overaction. You don't know whether it is a true inferior oblique overaction or it is a pseudo overaction due to the left superior rectus underaction. So because left superior rectus and right inferior oblique are yoke muscles, isn't it? So if it can be either a secondary overaction of the right inferior oblique because your left superior rectus is underacting, or it can be a true inferior oblique overaction of the right eye. So in that case, what you need to know is you cover the right eye and see the elevation of the right eye in right eye. So if the superior rectus is normally acting, then you can know that your right eye is pure inferior oblique, true inferior oblique overaction. If the left eye is not elevating, then it is a pseudo overaction of the right inferior oblique. I hope you understood.
Yes.
Yes. Okay.
So, madam, elevation in abduction, right, superior rectus.
Yeah, means if you're adductions, you can do if you are doing adductions, you can do supraadduction, infraadduction, right, adduction and abduction. Only versions you will do the other thing.
Could you explain once, please? Sorry.
Yeah, no problem. It's okay. So see, if you are doing adductions, you have the 9 cardinal positions of gaze. So you will be doing right, left, right up, right, right down, left down. So if your versions are normal, that means you are seeing all the muscles are acting properly. Your adductions will always be normal. But if your versions you see there is some overaction, you cannot write it is overaction unless you see the other eye under eye. So what you have to do is you have to look for the under correction of the under action of the muscle. That's why you are doing adductions. So see, just imagine if you have a right eye inferior oblique overaction. So right eye inferior oblique overaction can be due to a pure inferior oblique overaction and true inferior oblique overaction, or a secondary overaction because of the left superior rectus underaction. If your left superior rectus is underacting, what happens? According to Herring's law, equal innervation will be given to the right inferior oblique also, right?
Right.
Yes.
Okay.
Yeah, so then you will get a pseudo overaction of the right inferior oblique. So you want to know that. So you close one eye and see if whether the left superior rectus is elevating properly. If your left superior rectus is elevating properly, then the other overaction is pure right eye inferior oblique overaction. If your left superior rectus is underacting, then it is a pseudo overaction or secondary overaction of the right eye. I hope right now you are clear.
Yes.
And ma'am, so if the patient's versions are normal in all cases, do we still have to go for adductions?
What?
If the patient's versions are normal in all cases, do
No,
we still have
if
to
versions
perform?
are fully normal, your adductions are always normal.
So we don't have to perform it in exam.
Ideally, you don't have to, but you can do just for the purpose. But usually, versions are normal, your adductions are normal.
Okay.
Okay, because you are checking both eyes, right, at the same time.
Okay, ma'am. Thank you.
Okay, now coming to the measurement of deviation. So you have Hirschberg test, alternate prism cover test. These are not important. Simultaneous prism cover test, Krimsky and cyclodeviation measurement. Only for those things which are important, I will explain in detail. So Hirschberg test. So Hirschberg test, how you should do? You just shine a torch. You should be exactly in front of the patient. So you shine a torch from one side and you see the reflex, it will be different. So there will be parallax errors. So there are some fallacies of these Hirschberg tests. You should do exactly from the center. Okay. And what you look at the corneal reflex. So usually you can either write corneal reflex is central, or it is falling at the pupillary margin, or between the pupillary margin and the limbus, or at the limbus. So if it is at the pupillary margin, you will say 15 degree. If it is between, you will say 30 degree. If it is at the limbus, you will say 45 degree. Okay. So 1 millimeter displacement is equal to 7 degree, and 1 degree is equal to 2 prism diopters. So it actually gives a apparent amount of deviation. That's it. You cannot say exactly this is the exotropia or esotropia, but you can apparently say while measuring, when you keep the prisms, because if you do the Hirschberg's reflex, you can start with that prism to measure your deviation. Otherwise, you cannot just start from 10 to 30, no? But if you measure this, you can say around 30. So you can start with your 30. Okay. And the Hirschberg reflex always do for near only. You don't do it for distance, only for near. Okay. So So how do you measure squint?
Ma'am, in Hirschberg's, where we ask the patient to look at the
Look at the torch. So that's what you won't get an exact measurement. This intermittent squint, you will get a normal, or you will be the reflex will be center, but still the patient is having a 40 PD diopter prism means deviation. So it's just an apparent means amount you are getting. Okay. Okay. So how do you measure deviation? It's using prism.
Yeah. You will place the prism
Mm.
apex towards the side of deviation in the deviated eye.
Yeah.
And
So
other eye,
you can,
fixating eye.
yeah.
To
Yeah.
do that, ma'am, first I have to see this fixation pattern, whether the patient is fixating properly, and just place the prism in front of deviated eye, apex towards the deviation, and ask the patient to fix with other eye.
Okay. So so you can either use a loose prism. This is what I have shown in the left image, and or you can use either a prism bar. Okay, so you have three translucent faces and transparent faces. So you looking through that. Okay, so you have two positions you should know, that is frontis position and frontal position. So what we usually use is the glass prisms, plastic prisms. So that you should be placed parallel to the frontal plane. So you should keep your prism in the frontal plane. Whereas frontis position is used for glass prisms. We do not use that. Okay, so you will keep the apex of the prism in the direction of deviation, as you said, but we tell in terms of base. So see, exotropia, we will keep the base apex away from apex towards the exotropic eye, right? But we'll tell base in. So you always tell in terms of base in. Understood, no? Exo
Yes,
base in,
ma'am.
meso base out, hyper base down, and hypo base up. But the apex will be in the same direction. But you will tell in terms of base. And if you are getting, and if you are doing, see, in a superior oblique palsy, you have to tilt the head and take the measurement. So in that case, you cannot keep the prism like this. You have to keep the prism parallel to the orbital floor. Okay. And if you are getting a large measurement, like a 70 PD, so if 70 PD, you don't have that much amount in your prism, loose prism. So what you cannot keep one over the other. So you can just split it between the two eyes. So first image I am doing, it is for esotropia. The two apex are inside, right? In the second image, the patient is having an exotropia. So the patient is holding one thing and I am also holding one thing. So you can split between the two eyes, but you cannot stock one prism over another in case of horizontal deviation. Okay, but if you have a horizontal plus a vertical deviation, you can stack. So I am keeping one base in prism and along with a base down or a prism in the last this thing. Okay. And what you do is, so you know your apparent amount of deviation from your Hirschberg test. So with that, you will start and you do an alternate prism test until you get no movement or just the opposite movement. So that will be your, see, there is no movement. So that will be your amount of exotropia. Clear?
Show this video once again.
Yeah. There is no movement. That is the endpoint. Now, this patient, this is one of my patient. She had a right eye exotropia, but her vision was very poor. I think hand movements in one eye and the other eye has good vision, 6/9 or I think. So in that case, you cannot do a prism bar cover test or what you call is alternate prism cover test. So what you do? Krimsky test. So Krimsky test, where you keep the prism, you will keep the prism in front of the deviating eye, poor vision eye, and you see the corneal reflex until it becomes central. And if you keep it on the normal eye, then you call it a modified Krimsky test. Okay.
The opposite base should be kept normal in the normal eye.
Yeah, always X, so base in and XT always base in. That's what you should think.
Okay. Okay.
Exotropia, it's base in. There is no question. Esotropia, it's base out.
Okay. Okay, ma'am.
So after that, you have to see, especially in case of an oblique palsy, you have to check the cyclodeviation also. So what is this test? Anyone can tell?
Double Maddox
Maddox
rod.
rod
Yeah,
test.
double Maddox rod. Can anyone explain how will you do a double Maddox rod?
We'll keep a white cylinder and a red cylinder, ma'am. And then
No, both red cylinder, both Maddox rods with vertically like this 90 degrees. See, both Maddox rods
At
in
right
means in
angles
front
to
of
each other. At right angles to each
Hmm?
cylinder should be at right angles to each other. No.
and then
We-
ask the patient to make and put a little bit of prism, and
Yes,
we'll ask
yes, that's
make
what you should
ask
do.
the patient to make both the cylinders parallel together, and that's how we measure cyclo deviation.
Yes, exactly. Very good. I'll show this video. Just see. So you keep the prism in front of both eyes, prism Maddox rod. Then you keep a prism to separate the images, base down or base up prism. Then ask the patient how he or she sees. So she is seeing like this. Then what I will do? I will rotate the Maddox until she sees parallel. Okay. Then you measure that from the trial frame. Okay.
Ma'am, this prism
Why
will
the
be
prism
on
is given?
in the
What?
deviated eye, or the one which have a palsy,
Any
or
eye
in
you
any
can
eye?
keep. It is just to separate the images. If you keep two Maddox rods and just shine a torch, you will see only one line. You have
Yes.
to separate the two images. That's why you
Okay.
are keeping a base prism, based on prism.
Based on prism, na? Okay.
Based on or base up, whatever it is, you have to just
What?
separate the images. That's it.
Okay. Okay.
Okay.
So you can keep in base in and base out also?
No. Base down or base up. Vertically, no? It will be, the Maddox rods are lined vertically. You will see a horizontal line. So you have to separate the two horizontal lines. Okay. So you have to vertically separate. You have to keep a vertical prism.
Any particular strength of prism, just one or two adapters?
No.
Something?
I usually keep in our trial frame, there is a 4 prism, no? So I usually keep it there because you cannot get any other prism like this, our glasses. But all other prisms you cannot just keep in front, no? It will be difficult. So I used to keep a 4 prism.
Okay. And ask the patient to see the target or pen torch?
Yeah, pen torch. So they will be seeing a line, a horizontal line. But if the patient is having a torsion, one line will be, means there will be extorsion, right?
Okay. Thank you.
So if you have a torsion, then what you should look for in the, if there is actually torsion in your fundus. So fundus, you know that your macula is in the lower 1/3 of your disc. So if it is more down, then it is extorsion. If it is up, even if it is here, just above this is intorsion, because it should be. So sometimes you may see it's in the half of the disc. It's the intorsion. If it is in the lower 1/3, it is normal. If it is more down, it is extorsion. If it is more up, it is intorsion. Okay. And you indirect, you will be seeing ulta, like the macula will be above the disc in extorsion, and if it is down, it is intorsion. This is a actual fundus image. Okay.
More down than the 1/3 is extorsion, and
Yeah.
it's above the normal position. Then it's
upper 1/3 also it is intorsion.
Intorsion, and in indirect,
Yeah.
it's reverse.
Yeah.
So right eye photograph is intorsion.
Right eye is extorsion. No. This is fundus image, right?
Okay.
This is fundus image. Fundus image, it will be down. If it is indirect, you will be seeing ulta, right?
So,
So
Dr.
it'll be
Ramya,
up.
please use
Clockwise,
a
it is-
pointer. Use pointer, Dr. Ramya. Pointer
What's
or
that?
cursor. Use a
Ma'am?
pointer. Use a pointer on the slide, please.
Yeah, this is the lower 1/3 of the disc. Okay. So if the macula should be actually in the lower 1/3 of the disc. So if it is lower 1/3, it is normal. If it is more down than the lower 1/3, then will be extorsion. If it is up, then here it will be intorsion.
The pointer is not visible actually.
Not
Dr.
visible,
Ramya.
ma'am.
You
No.
can use the cursor over the
Cursor.
screen.
Just 1 minute. 1 minute. Laser pointer. I got it. Now it's visible, right?
Yes. Please go ahead.
Okay. Thank you, ma'am. So see, this is your disc. So this is the lower 1/3, right? So normally your macula should be in the lower 1/3. So if it is more down, then it will be extorsion. If it is above this any level, it is intorsion. So even if it is here, it is intorsion. If it is down, then it is extorsion. But this is your actual fundus image. But if you are seeing indirect ophthalmoscopy, it will be ulta. Like you will be seeing macula here, then it is extorsion. If it is down, it is intorsion. I hope you understood.
Because the indirect is the image is inverted. Okay, so indirect, the image is inverted.
Yeah. Yes,
So in
ma'am.
order, yeah, in extorsion, the macula will be high, very up, like very opposite to this image.
Yeah. Okay. So what
Thank
is
you.
the other importance of looking at the fundus image? Fundus, in any case, if the child is coming with a intermittent exotropia, you will say whether it is intermittent XT in that case. Unless you see the fundus, you cannot comment on the squint, because you should know that, because sometimes the child may be having some retinoblastoma or something, and the child is intermittently squinting. So unless you see the fundus, you should not comment on the squint. Squint. See, this patient is having a papilledema. The first image, you can see the bilateral disc edema, papilledema. She presented with a esotropia, sixth palsy. So it's very important. In this case, the patient had a macular scar presented with an exotropia. So you should know, unless your evaluation is fundus evaluation eye evaluation is complete, you cannot comment on what is the exact cause of the squint. Okay. Coming to some special tests related to squint. This is very important. That is the Park 3-step test. So I hope you know there are 3 steps. First step, you will see which eye is hyper, whether it is the right eye or the left eye. Then after that, you see, does the deviation increase either right gaze or left gaze? Then you see whether the deviation increases with your head tilt to the left or the right shoulder. The last part of this test is known as the Belshowski head tilt test. Okay. Okay. So one of you please tell me. Look at this girl. Which eye is hyper?
Right eye.
Right eye.
So if the right eye is hyper, either the right depresses or the left elevators are affected, isn't it?
Yeah.
Yeah. Depresses or the left elevators are affected. So now see, this is someone asked me now, how do you do the tilts? And also either I can tilt the head for the if I turn the head to the right, the child's eye will be to the left. If I turn her to the left, it will be going to the right. I can do right like this, or ask the patient to look to the right and left. So, like that A pattern someone asked now, how do you measure the deviation in up and down gaze? So you can move the head in up or down so that the eye moves in the opposite direction. Okay. So tell me what happens in the which gaze it is increasing in this one? Which gaze?
In the left
Worse
gaze.
in left gaze. Worse in left gaze.
Yeah, left gaze, which all muscles are acting?
That right
Inferior oblique and the
oblique.
left superior rectus.
Yeah. So your right inferior oblique means obliques will be acting in the right eye and the recti will be acting in the left
Rectus.
eye. So you understood, no? Okay. So now you come to the tilt. So just see which eye is more hyper, left or right?
On the left it's high. On the right tilt it's normal.
Just see.
On the right tilt it's improving.
No. Right, it is more, right? See this. See, look at this eye. This is more. This is less actually. Sorry. Okay. So
Yes,
maybe, yeah, it's right. So you are right. So when you tilt your head to the right side, your right intortus are acting. When you tilt your left to your left side, your left intortus. So whichever side you are tilting, that side intortus is acting. So here it is right eye. The deviation is more in the right tilt. So right superiors or the left inferiors are getting affected, isn't it? So which muscle is getting involved?
Superior oblique, right
Oblique.
superior oblique.
Right superior oblique. This is how you should do a parkinsonism. There are many fallacies for this test. You cannot do for multiple fallacies or restrictive strabismus, thyroid and all you cannot do. So only in a single muscle, cyclovertical muscle, you can do this test. Okay. But you should know this test, how you should do, how will you go about, and what is the diagnosis. I hope you understood.
So basically, in a
Ma'am, can we simplify it like this? Means what I understand, actually right eye hypertrophy is there. So
Yeah.
in the second step, it is increasing in left gauge.
Yes.
So left gauge means either left gauge means right eye in adduction and left eye in abduction.
Yes.
So either it is right superior oblique or
Yes.
left superior rectus problem.
Left inferior rectus.
1 minute, 1 minute. Left inferior, wait, ma'am. Going like that, no. Left hypo, no, ma'am. Left superior rectus.
Yeah, left superior rectus, but that is already ruled out, no?
No.
Yeah, left superior rectus, sorry.
Yeah. So in step 2, I am cutting to, coming to 2 muscle, and in step 3, when I am tilting, as it has been more in right and less in left, so it is gone to 1 muscle, that is right superior oblique. I used to remember like this way.
Yeah. That's enough. More than.
Ma'am, one doubt in Chua site, in all these cases, they do cover test. Is it necessary?
Yeah, ideally you should do, because actually in exam they don't ask, but if you have to plan a surgery for this case, I have to do measurements in all 9 cases and find out which surgery I should do. Depends on which gaze it is acting maximum, which it is the measurement is maximum. So superior oblique you can do superior oblique, congenital superior oblique palsy you do superior oblique tuck, inferior oblique recession, other eye superior rectus if there is contractile recess. So you can do. So you have to measure the deviation in all 9 cases. Unique squint. But comitant squint usually will be equal in all cases, but ideally you should do in all cases. Especially these types of incomitant squints, 100% you should do. Then only you can plan the surgery.
Ma'am, doing the steps, no, step 1, step 2, step 3. Will you do the cover uncover test, or will you see in just
cover uncover, alternate cover test.
Alternate cover. Would you have to confirm it by doing alternate cover? Okay.
Yeah, but you can just see, means if you see the hyper, you can when you tilt the head only, the eye will be more moving up in one gaze. So you will come to know if you just tilt the head.
No, I actually without doing seeing it is comfortable, but doing cover uncover, no.
Yeah, that is because
more...
sometimes, even sometimes these dystopias can occur. No? So it's better to do the cover test and see which gaze it is maximum. That is the definite test.
So when we're doing the cover uncover in all 9 positions, where will the patient be looking? Like, because
distance,
obviously
always distance. They have to read this distance chart.
Okay, even in the left gaze and right gaze, they have to look at the chart.
Yeah. So that's why we usually don't ask the patient to look to the right and left. Instead of that, I will tilt the head. I will turn her head to the right side so that the eye goes to the left side.
Right.
Okay, so that the patient can read comfortably. Otherwise, how can a patient read to the left, means gaze to the right side and read the distance chart? It's not possible, right?
Yes.
So I will only tilt the
Yes.
head so that the eye is in the other gaze.
Okay. Thank you.
While doing the cover test, I could see the corneal reflex. Is it because you're taking the photograph, or usually we don't require to use the corneal reflex while doing cover and cover, no, ma'am?
Yeah. This is for this is just for it means to show you I have done this, no? But you'll be able to make out which gaze it is maximum, because your inferior oblique overaction will be more, no, in the other gaze.
Okay, no, and normal cover test also, ma'am. No need of
what?
No need of I've seen corneal reflex. All the patient need only fixate on the distant target, no, ma'am. That's sufficient, no?
Always fixation. Always fixation for distance.
And okay, fine. Okay, you should not obstruct the view.
Yeah.
Right.
Okay. So there is one more test for prism base out test. Can anyone explain this? How do you
It is
do this?
to rule out the microtropia, central scotoma.
Yeah.
But
So when you do this, when a patient coming with a the patient will be having one eye 6/6, other eye will be 6/12 or 6/18, but all other tests are normal. So you don't know why the patient is having decreased vision in that eye. So in that case, you should find out whether there is a microtropia. Your cover test may be sometimes orthotropic, but you should know whether there is a microtropia. Yeah, tell me.
You place the prism on the first time, ma'am. Then you'll see a corrective movement in that eye, and then corrective movement, then opposite eye also will move outward, and then finally the both eye will come to a standstill. But in case of microtropia, there will be no corrective movement, because the stimuli will fall on the scotoma, the microtropia scotoma of the microtropia, and that's why there'll be no corrective saccade which is seen in the microtropic. Correct, ma'am?
Yeah. So if you place it in the case of normal eye, so base out, right? So apex is in. So eye will move in that eye, the other eye will move out, corresponding movement. Then again the other eye will be coming in and taking up the fixation. But if you keep it in front of the amblyopic eye, it will not. There is no movement in that eye. So correspondingly, the other eye also will not be having any movement. Okay. You can see the slight movement in the other eye. This you can see no movement. See, no movement. So base out prism you will keep. Okay. So now we go to some case scenarios. Are you all okay? It's too much?
yes, ma'am, continue.
Continue, no? Okay. So okay. Okay. Someone please volunteer and tell me. This is a 5-year-old girl. She was brought to me with her parents by her parents, saying that she has squint and her vision is 6/6 both eye with good stereo acuity. Okay. This is the child. Now I am doing the test. Just see. Yeah, sorry. Why this video is not working?
Yeah, change the pointer, Dr. Ramya.
Oh, okay.
Remove the pointer.
I'm not familiar with these things. Sorry.
It might help. I don't know.
Yeah. So this is what I told, no? When I am doing the cover test, see, I am allowing the patient to fuse in between. Now I am doing the alternate cover test. Before that, I was doing the cover test. Okay, tell me, someone, please.
So there is, and I think in cover and uncover, there's no any movement.
Yeah.
Patient, it's orthophoric while on doing the cover and cover.
Yeah. So what is this?
This thing pseudo-strabismus due to
Pseudo-strabismus. It's a pseudo-strabismus. Pseudo-esotropia because the the parents were telling the eye is inward.
Yes,
I
think this is because of the wide gaze, wide distance
between broad nasal bridge.
Nasal
Can you see?
Yes, broad nasal.
Broad nasal bridge. So this part of the sclera is not that visible compared to this part. So 1 minute, let me take this. Yeah, this part of the sclera, the medial sclera is not that visible compared to the lateral sclera. So it is looking like as if the eye is gone inward. So actually it is a pseudo because when you do a cover test, you look at the movement of the first you do a cover test, you cover this eye, look at the movement of this eye, then you cover this eye, look at the movement of this eye, then you do an alternate cover test also, so that you can make sure that there is no phoria also in this patient at all. So it is a orthophoric patient. So it's a pseudo-strabismus, pseudo-esotropia.
It is a case of telecanthus, ma'am.
What? No. Actually, we can no. It was not telecanthus. Telecanthus means I think the measurement should be more than, I am not sure of the amount centimeters. Then only you will tell it is telecanthus.
Telecanthus interpupillary distance also will be increased.
Yeah.
Not
More than
only in epicanthus, only the interpupillary distance will be the same, but the lateral canthal distance between the medial canthal distance will be more.
There is something like it. I'm not remembering. One is a radiological diagnosis. One is a clinical diagnosis.
There
So
are
I'm not
two
sure which one is.
telecanthus and hypertelorism.
Yeah, that's what. Telecanthus and hypertelorism. One is a clinical diagnosis. One is a radiological diagnosis.
Hypertelorism is wide intercanthal distance.
No, telecanthus is wide intercanthal distance.
Okay. Okay.
so
this case of
telecanthus would be. No, I was just telling you that telecanthus is when the intercanthal distance is more than 50% of the interpupillary distance.
Yes.
That's when we calculate telecanthus. And in hypertelorism, your intercanthal distance, interpupillary distance, and they all are increased.
Okay, thank you. Okay. So so pseudo isotropia. Normally when you do a Hirschberg reflex, it will not be exactly at the center, right? It will be slightly nasal. So when you do most of these patients will be slightly nasal, like a mild exotropia. So why this is happening? Because of your angle kappa. So there is a angle between your pupillary axis and your visual axis. So this is called angle kappa. That's why you are getting a slightly nasal shift of your Hirschberg's reflex. Okay, if this angle is more, then you will get a pseudo exotropia. It's very large. You can get a pseudo exotropia. If it is to the other side, you can get a pseudo isotropia. So you have a negative angle kappa, you will get a pseudo isotropia. You have a positive angle kappa, you will get a pseudo exotropia. And like other things like epicanthal folds, short interpupillary distance, broad nasal bridge, all these give rise to a isotropic appearance. It's actually not an isotropia. Like that, wide interpupillary distance, positive angle kappa, all these give rise to an exotropic appearance, but it's a pseudo exotropia. Okay.
Ma'am, in
have to
exam,
just
whenever when you, in inspection, when you say no, you're excluding pseudo, exo, or SO. So how will say the angle kappa? We don't know how to measure it.
No, examination, you have to just say it is a pseudo isotropia. If there is an obvious cause, you see like a broad nasal bridge or epicanthal folds, you can just think like that. The examiner will ask about angle kappa. That's all. You don't need to measure it. So if you do a cover test and there is no movement, this could be due to all this. If it is not due to all this, then it could be due to a positive negative angle kappa in a case of pseudo ET, or a positive angle kappa in a case of pseudo XT. So that also can drag the macula in ROP, means premature children also can lead to these angle kappa problems. No. Okay.
Okay, ma'am.
Yeah. So now we'll go to the next case. Okay. This 6-month-old baby was brought by the parents, full-term normal delivery, all other things normal, no NICU admission, developmental milestones are normal. And he had the child presented with an inward deviation of 5 since birth. Okay.
Infantile esotropia.
Don't jump into the diagnosis. You just see the video and see. Tell me. Okay. Yeah.
There is large angle of deviation and the child is cross-fixating.
Yes.
So in side gauge. In primary gauge, there is esotropia and cross-fixation in side gauge.
Yeah. Okay. So usually infantile ET usually presents in 6 months or less age, and there will be a large amount of deviation, and there will be cross fixation. When you are showing something to the right, the child is see with the left eye, and to the other eye, other side with the other eye. So it will be looking like an apparent abduction deficit. So what you should do?
I should do, ma'am,
Obstruct one eye.
False eye maneuver to see.
Doll side maneuver.
Doll side maneuver you can do. What else? Doll side, otherwise
one
close
eye.
one eye, occlude one
Ductions.
eye, and yeah, you should look for ductions. It will come. Okay. So that's what I should do. And also you should look for inferior oblique overaction. Most of this infantility has an association with inferior oblique overaction, dissociated vertical deviation, all these things.
Madam,
Okay, so this is the cross fixation what I have shown.
so we
So
should
the features of
IO overaction and DVD, is it present in earlier age or develops later?
it can present earlier, also it can present later. Sometimes what we so the management also, it's there are two schools of thought. So if you do MR recession early, but sometimes the patient can develop a DVD at a later stage. But if the patient has a DVD at that, means it's not present that time, but if you wait and do, you can manage both at the same time. So there are different schools of thought. It can present at the time of this one, also it can present later, but sometimes later a DVD can be latent, so it will manifest, it will take some time, no?
Ma'am, how to differentiate this in this cases there is a no sixth nerve palsy?
Yeah, that's what I told. You close one eye, patch one eye for some time, and then look at the adductions. Then the other eye will come, the uncovered eye, then the will go to the means abduction will be present.
No, is this possible to do this in the small child if she will?
Yeah, definitely you have to do. Okay, how can you?
No,
Because
she will
otherwise
follow
I
the object. Okay, she will follow.
otherwise how
No.
will I means I can tell this is a bilateral sixth nerve palsy, no?
Yes, I was about to say this. This is bilateral sixth nerve palsy on
No.
cross.
So unless you do it, that's the importance of adductions.
Okay.
If we do that lateral rotation of retina, that means doll's eye head, it will give the impression also, no, ma'am?
It will give, but it's the child will be resisting because they are used to this cross fixation, no? So it's very difficult to rotate the head of the child in that direction because most of the child will be resisting. So instead of that, if you patch one eye for some time, the child has to look from at the other side, no? So the child will look.
See the fundus, then only find out your diagnosis. So in such
Yeah, that's what I told. So sixth nerve palsy can be, so you should rule out the fundus. Unless you see the fundus, you cannot fully diagnose any case.
this child have fundus.
Yeah. Oh,
so, Dr. Ramya, can you repeat the video, please? Replay the video.
Yeah, definitely. Sure, ma'am.
Someone is asking.
Okay.
Thank you.
So these are the associations. So one is cross fixation. So these patients usually having, because both eyes are using, not at the same time, but each eye is using at least means when one eye is using, the other eye is in, when the other eye is using the other. So most of these cases doesn't have any amblyopia. So stereo acuity will be very less, but amblyopia won't be there. Most of them have 6/6 vision when we see them. And large angle esotropia, apparent abduction deficit, it's apparent abduction deficit. Actually, there is no abduction deficit. And inferior oblique overaction in 70% of cases. And there can be dissociative vertical deviation in 75% and even dissociative horizontal deviation also. And latent nystagmus is present in 50% of cases. Okay, these are the associations. Yeah.
Infantile esotropia is always bilateral.
It may not be. Sometimes the child may be using only one eye. Means it can be, there can be a preference. There can, it means if there is a left esotropy, the child will be fixing with the right eye more frequently than the left eye. There can be an amblyopia. In that case, you should patch the child unless the child becomes alternating. Then we'll take up the patient for surgery. But it can be. So you should know. You should see whether the child is alternating or it is a monocular esotropia. If it is monocular, you have to patch the other eye and treat the amblyopia first, and then you take up the patient for fixation surgery. Okay.
So in this congenital
when you do cover
esotropia,
test, then you will come to know. What?
Okay, in this cover congenital esotropia, we have to do bilateral medial rectus recession.
Yeah, we do generally bilateral medial rectus recession.
Okay,
ma'am, tell us the time when it should be done.
Yeah, that's actually, there are different schools of thought. So previously they used to say it should be done means early so that the child gets a stereo acuity. But if the child is having means especially one eye preference, there is no point. Means we have to treat the amblyopia first. and then only take the patient for surgery. And even if the child is having a cross fixation, there is chance of medial rectus contracture also. Your measurement means your surgery can also be difficult. So if you patch eye for some time, the medial rectus won't be that tight. So I means what I prefer is after means just 2 years of age. That is the time when you do means 1.5 to 2
Ma'am,
years of age.
I have
And you
few
should get
practical
a
questions.
measurement. You should be able to get a measurement also. You cannot just do like that. No, you have to get a measurement. The child should be cooperative to get a measurement of
Ma'am,
deviation.
there is a cross fixation, no? It has been told that
Yeah.
chance of amblyopia is less. And
Less, yeah.
sometimes the refractive error might be +1 or 2. So in that
Yeah.
age, refractive correction is not also required.
Yeah.
And
Yeah.
sometimes there is no
Yeah.
amblyopia. In
Yeah,
that scenario, no.
any case of esotropia, what I do is if there is cycloplegic refraction is more than 1.5 diopter, I straight away give glasses first. Because there could be an accommodative component. So in any case of esotropia, if the cycloplegic refraction is more than 1.5, first give glasses, then see the squint again, and also do patching. And because
Together.
sometimes even yeah. Even +1 or plus 1.5 or 2 can reduce the amount of squint. So there is it means you can always give glasses and then see again.
My question was that if there is no such refractive error and no amblyopia, patient is seeing. So
Yeah.
one will going to operate the child.
If you can get the
theoretical.
as soon as you get the measurements, you can operate.
Okay.
Yeah, you should get the measurements. That's all. Because in that case, you want to get the child stereo acuity, because the child is having good vision. Then the next thing is stereo, no? So you can as early as you do your surgery.
Ma'am, other thing is that somewhere I read in the amblyopia treatment, first treat with full glass correction. Don't give patch. So I don't know what is the source.
Yeah, that's what. First glass, then patch, then surgery.
So glass for 3 months, then patch, like that?
Yeah, glass, call the patient after 2 months or 3 months and just see again. And how the vision, how the fixation, depending upon that, you can start patching. Then once the child is alternating and you get a measurement, you plan for surgery.
And the surgery is first in the amblyopic eye.
If the child is having a left esotropia, even with the glasses, you start patching of the right eye along with the glasses. I mean, start glasses and call them after 2 months. If the child is still fixing with the left esotropia, fixing with the right eye, close the patch the right eye so that the child uses the right eye, left eye. Means amblyopia should be corrected. Okay.
Okay, ma'am.
Understood. Okay. So this is what I told. Glasses, if the cycloplegic refraction is more than 1.5, treat the amblyopia using your occlusion therapy. This will be a very small child. You cannot use any other method. You can use your occlusion therapy and surgery, usually medial rectus recession. Okay. So one of you please tell me. This girl, 4-year-old girl, presented with squinting started around 1.5 to 2 years of age. And the when I did the cycloplegic refraction, it came up to +5 diopter. How will you go about in this case?
We'll give classes and check whether it's fully accommodative or partially accommodative.
First, we have to do the refraction.
Refraction done, no? Cycloplegic refraction is +5.
Yeah, sorry.
So if glasses, if it is correcting by glasses, it is fully accommodative. It is not.
So we will give the full correction to the girl.
Okay.
And then we will
You would give a
review
bifocal.
after 3 months. And
We'll also check for amblyopia and do patching in this patient.
Yeah. So what you have to do is you are getting +5 diopter, right? So the child is squinting. It's started around 1.5 to 2 years of age. So you give full correction and you call the patient after two months and see whether the squint is getting corrected for distance and near. That should be there, distance and near. If it is fully getting corrected for distance and near, you have to continue glasses. And if the child is amblyopia, because this girl mostly having a right eye amblyopia, because the right eye is squinting. So in that case, you have to start patching after 2 months. And the squint is getting corrected. You don't need to do anything for the squint, but treat the amblyopia. Understood? But if you call after 2 months and the patient is corrected for distance, but there is still ET for near, then you know the child is having high AC by A ratio. Then you ask, then you make the glasses to bifocal glasses. Actually, it is executive bifocal bisecting the pupil. Okay. Then you call again after call again after 1 month and just see whether it is getting corrected for both distance and near. Actually, you can give this at your OPD and do a cover test. Then you will come to know whether the near it is getting corrected. Then that according to that you can give glasses also. Okay, and correct amblyopia. Yeah.
Dr. Remya, don't we do an AC by A ratio evaluation in the first
You
visit,
can
or
do.
do
You
we
can do.
wait?
Yes. You have different methods. No, gradient method, heterophoria method, with the
Yes,
glasses as well as the with the distance. You can do that also. Okay.
right.
So
Thank you.
this patient of mine, she needed because her power was high. I had to give it. Actually, this was this executive bifocal was not getting, so I did this. So she was ortho for distance as well as near. So it's a accommodative esotropia with high AC by A ratio. This girl. So usually accommodative ET, it is a moderate hyperopia. Onset is a usually because child will be normal by means around 1 year of age. Because even during birth the child will be sender, but usually it starts around 1.5 to 2 years of age. And deviation varies with the amount of accommodation exerted. So when the ask means sometimes you may not see squint, but as soon as you give some target and ask the patient what is this, the child will start squinting. So it is the deviation varies with the amount of accommodation exerted. That's why it's usually you can see it more for near, and there can be asthenopic symptoms as well. So this is what I told. If it is ortho for distance and near, you just call it as a refractive accommodative, fully refractive accommodative esotropia. Then if it is ortho for distance but not for near, then it is either could be a non-refractive. Even without refractive error, you can have this. Or accommodative ET with a high AC by ratio. Then deviation reduced, but it is but not ortho for distance. It is a partially accommodative, because previously it was 40, but after glasses it came down to 20. Then it is partially accommodative. Then another entity is there, hypoaccommodative, where the NPA is receded, where normal AC by ratio. So here you give glasses, the other two you give bifocals. Then there are procedures like Faden, where you weaken the medial rectus muscle, and Botox also you can use. Okay. So at least these things you should know. Okay. Shall I move on? Continue.
Yes,
Yes,
ma'am.
ma'am.
Okay.
Rounds.
That's it. Okay. Okay.
So Brown syndrome.
There's
What did you
limited
say?
elevation
You
in
want me to
adduction.
play again? Yes. Effective elevation in adduction. So diagnosis?
Brown syndrome.
Yes, Brown syndrome. Which eye?
Left eye.
Right eye.
Right eye. So
Right
always
eye.
tell. So don't tell just without eye. So you should tell it is right eye Brown syndrome. Okay. So otherwise, how do you know whether it is the right eye or left eye? So mention
Ma'am,
the
can you please
yeah.
again play this video?
Hmm.
Turn.
So, madam, there is a
Yeah.
downshoot also in the right eye.
What?
Downshoot in the right eye.
Yeah, downshoot that will be there. No, usually in Brown syndrome there is a mild downshoot in the right on adduction. Mild. Okay. So the case of there is defective elevation in adduction, but there is less elevation deficiency in the midline, and there is minimal to no deficiency in abduction. So, but the thing is that it can be due to an inferior oblique over palsy also, right? Because your adducting muscle is inferior oblique, right? But what happens in inferior oblique palsy? There will be a superior oblique overaction. But in Brown's, there will not be superior oblique overaction. That is the difference between inferior oblique palsy and a Brown syndrome. Okay.
Can you please repeat that again, this Brown and inferior oblique?
Yeah. See, as you know, if there is a palsy of one eye, the opposite muscle will be overacting, isn't it? That is your Sherrington's law. I mean, yeah, Sherrington's. If one muscle is overacting, the other underacting, the other opposite muscle will overact.
Yes.
If superior oblique is underacting, your inferior oblique will overact. So here, in the adducted position, this eye is not elevating. So adducted position elevation is done by which muscle? Inferior oblique. Isn't it?
Yes. Yes.
Yeah. So it is actually an inferior oblique. It looks like an inferior oblique palsy. But if it is inferior oblique palsy, there should be superior oblique overaction, right?
Yes.
But here it won't be that. It won't be there. So, yeah, in Brown syndrome, there will be an inferior oblique underaction. It means like a adducted position, the eye is not elevating, but there won't be superior oblique overaction. Okay.
Yes.
Ma'am,
So
how
there is a
will
V
you
pattern.
check superior oblique overaction in depression?
How will you? You only tell me. How will you do?
Depression in adduction, right?
Yeah. So you ask the patient to dextro depression. Sorry, levo depression. So if in the levo depression, this eye is more going down compared to this eye, then there can be a superior oblique overaction.
Overaction in the same eye, right? In the same eye.
Yeah, same eye, same eye.
But ma'am, in your video, when the right eye is in adducted condition, no, the eye is moving down. So
That is
how
not
can
inferior. That is not superior. You have superior oblique overaction should be in the gaze. The
Primary
dextro,
gaze.
sorry, left levo depression. That is just a downshoot. They're just slipping down, downshoot. This is
So
not
but
an
in
oblique
exam,
overaction.
in exam, it will be possible from us to exclude it is not superior oblique overaction.
But
Rather,
when you see this pattern, you know that this is a Brown syndrome. You will come to know.
yeah. So
Inferior oblique
is there,
overaction, inferior oblique palsy is very, very rare.
So
ma'am,
we have to
is there any role of doing forced action test?
Yeah, yeah, there is. These all are restrictive type of squints, right? This is, yeah, this actually I think the recently this has classified under CCDD, cranial disinnervation disorders, congenital cranial disinnervation disorders.
So what we will
Like
get in FEDT? If we are
FDT, you will have a restriction.
Okay.
Okay.
Madam,
How you will do it, ma'am?
Yep.
How what to do and which direction will move?
You have to do it. Actually, this is not an FDT. This is called the this exaggerated guidance, exaggerated duction test for obliques. Okay, this is not for duction. This is for obliques. So you will come to know there is a less movement. There is I don't know whether it means there is superior oblique and inferior obliques. What you do is you just hold the limbus at 10 o'clock on the 4 o'clock positions, and you move the depress the globe, and then you move the eye adduct and abduct. Then you will see how much part of the cornea is going under the lid. According to that, you can grade the amount of field restriction.
Yeah. Yes, ma'am.
Okay. Okay, so this is positive. So Brown syndrome is otherwise known as a superior oblique tendon sheath syndrome. So here what happens is superior tendon is not able to relax actually. It's not an inferior oblique problem. It actually superior oblique tendon doesn't relax. So it can be either congenital or acquired. So in acquired cases, sometimes what happens is this trochlea, there's some inflammation happens. So in that case, you can get a superior oblique Brown syndrome. So sometimes rheumatic nodule also can host this type of acquired Brown syndrome. Okay, and the patient sometimes feel a click at the supraoinmedial part of the orbit. Okay, so this is what you asked. Downshoot in attempted elevation in adduction can happen, and click felt on the trochlea in acquired cases. So how do you treat these cases? If it is a congenital Brown syndrome, you see whether there is a normal head posture of or the patient is ortho in primary. In that case, you should not do anything. You just leave the child. Okay. If there is an abnormal head posture with a severe chin up or hypertrophy in primary position, you take the patient for surgery. In acquired cases, if there is a trauma, you should explore that area and see what is happening there. If there is an inflammation, you can either wait or start steroids so as to reduce the inflammation, and it gets relieved. And if there is an iatrogenic, like in a case of superior oblique palsy, if you do superior oblique tuck, sometimes this can lead to an iatrogenic Brown syndrome. In that, what you have to do, you have to release that tuck. That's it. And if it is much more, then you have to do that. You need not know contralateral SR. Okay. I hope this table explains everything about the management of.
Ma'am, in the congenital one, which type of surgery? That one, superior oblique tucking.
Yeah, no. What did you ask? I didn't get the question.
I'm asking in congenital, what type of surgery we will do?
Yeah. So here what you do is you have to elongate the Brown superior oblique. What you do is either a chicken suture. 1 minute. I don't have that slide. Sorry. So you have to do what you have to elongate the superior oblique. Okay. So what you do is a silicone spacer, or what another one is a chicken suture. You just elongate the superior oblique tangent. Okay.
Okay, ma'am. Thank you.
Yeah. Anything else?
Is it the same?
Once what you are doing is a superior oblique weakening by superior oblique tenotomy. You can do a superior oblique silicone expander or a superior oblique chicken suture. This is what you do in a case of Brown syndrome.
Okay, not the tendon, muscle. Or we have to do on the tendon this?
Tendon. Okay.
What actually done, ma'am? That silicone just.
So what you do is you cut between the superior oblique you cut, and in between you will keep a silicone spacer or silicone band. Or you can also make a non-absorbable suture in between that. You can make a 8 millimeter length, and then that muscle length will be getting elongated, right?
Okay. The tendon encroachment, the area will be more.
Yeah.
Okay, got it.
Okay. Yeah. Okay, so I'll move on to the next slide. Okay, this is okay. This one. Okay.
Double elevator palsy.
Right eye elevation defect in all cases.
Explain the finding. Don't jump into the diagnosis first. First, explain what is happening with the movements. Okay. What happened in the first video?
When the right hypotropic.
Yeah, when I covered the left eye, there was an upward movement of the right eye. So the right eye was hypotropic, isn't it?
Yes.
Please, yeah.
See, when I, sorry, no, not this side. That, see, look at this. Yeah, see. They're gone. Not now. Just see. See, look, see. It's gone up. So when I covered the left eye, the right eye gone up. So actually it was down. So this was a right hypertropia. Then in the next thing, what is happening? This
Ocular movements. Limited.
Close the door properly.
Elevation.
So there is limitation
defect in
of
all cases.
elevation.
Yeah. So the right eye is not elevating in abduction, adduction, and in primary midline. Okay. So that's why it is a double elevator palsy. That's how you differentiate a Brown syndrome from a monocular elevation deficit. So you call it as monocular elevation deficit. Double elevator palsy was previously used. Now we use monocular elevation deficit because the etiology has different things. So now we don't use double elevator palsy. Okay. So understood?
So this is a
Got it?
difference down only on the adduction, the elevation is defected, but in this monocular and whole horizontal plane from abduction.
Yeah, from adduction to abduction. All area, it will be elevation is affected.
Okay.
What is the treatment?
So, what?
What will be the treatment?
That I will come to know. So the child will be sometimes can have chin elevation because the child is hypotropic, no? So hypotropy of the involved eye more in the up gaze because up is not going. So it will be more in the up gaze because depression is normal. Limitation of elevation in adduction, straight up gaze and abduction, but fusion will be there in the down gaze. And this can be associated with a pseudo ptosis. First case I told in the inspection part. Remember the first case, pseudotosis. Okay.
Yes, ma'am. Yes.
Yeah, this can be associated with a pseudotosis. Sometimes there can be a true ptosis also associated with a monocular. But you have to see with the fixing. When you ask the patient to fix with the ptotic eye or the hypotropic eye, you will come to know whether there is true ptosis or a pseudotosis. Okay. So for any case, you treat the amblyopia, and if there is no or minimal head posture, you observe. And the management depends upon your FDT. So actually, you do FDT for inferior rectus. So if your inferior rectus is restricted, I mean, if you have FDT positive, then you do inferior rectus recession. And you also should look for the superior rectus action. So if the superior rectus is not acting, you can do actually superior rectus resection also. These are divided in according to the etiology. This MAD is divided into primary inferior rectus restriction, primary superior rectus palsy, secondary inferior rectus restriction due to a primary superior rectus palsy, and a supranuclear one. So you don't need to know that, but ideally means main surgery is inferior rectus recession. That you should know. Inferior rectus is recessive because hypotropic, no? So inferior rectus will be contract. There will be contraction. So you'll recess the inferior rectus. That you should know. And another one is NAPS procedure. Have you heard this name before? NAPS?
No, ma'am.
Okay. NAP is nothing. There is you will be keeping your superior if the superior rectus is not acting, no, you can keep your lateral and medial rectus towards the superior rectus so as to give elevation in that eye. Okay. So it's like a transposition procedure. Your superior rectus is not acting, so you want elevation. So what you do is you take that medial rectus and superior lateral rectus towards the superior rectus. So you'll get some elevation.
Lateral rectus, no, only?
You can take, means there are total naps, partial naps. There are different methods. I just told this is a transposition procedure. You can do partial also, full tendon also. You can do.
No, you're taking only lateral rectus in consideration, no, ma'am?
No, you can take medial also.
Achha, medial also. Okay.
You can take. It depends on the what the surgeon's preference, what is the patient's profile, all depending on all that. But normally, if it is a small deviation, you can do just inferior rectus recession. If you do, means if you have a SR palsy and all, you may have to do an abs procedure also. If you have SR palsy, but the SR has some function, you will go for SR resection. Otherwise, if there is a total palsy, SR is not at all acting, then you cannot do SR resection. You have to do go for an abs procedure. And after that, once you manage the squint, if it is a pseudo squint, your ptosis will be getting corrected with your squint because it is actually a pseudo squint, right? But if there is true ptosis, then you have to manage the ptosis according to the normally ptosis what you do for like sling and all. Okay. So you do surgery in vertical if there is a vertical deviation in the primary position and deviation causing a severe amblyopia. In that case also you have to do this. So I think final case. Okay. This is a child. Okay, 4-year-old boy, left face turn, noted since 6 months of age, but good vision in both eye. Okay. In the preferred head posture, see in this head posture he is ortho. But LET in the primary position he is left isotropic in the primary position. Now I'll show you the video. Okay, tell me.
Video again, ma'am.
Oh, video. Okay.
Left lateral rectus not working.
Observe, observe, observe. Inspection, I have told something, no? Just see that. What do you see when he is abducting, when he's looking to the left side? What do you see when he looks at the right side?
Right eye is acting, ma'am. In left gauge, lateral is not working.
Lateral rectus is not working. Along with that, do you see anything else?
Yeah, it's
There's narrowing of the palpebral fissure.
Yeah, when he looks at the left side, left eye is not abducting, but along with that, there is widening of the palpebral aperture. And when he looks at the right side, you can see the left eye is narrowing, and there is mild retraction also of the left eye. Okay. So this is a case of
Left eye isodRS.
left eye isotropic Duane's retraction syndrome type 1. That is the correct diagnosis. Isotropic Duane's, no? It's the primary previous slide. Isotropic Duane's. See, the primary portion, the eye is isotropic. So left isotropic Duane's retraction syndrome. Since the abduction is affected, it's a type 1. Because since the child is keeping the head in the left face turn, the child has good vision in both eyes, BSVs, because he is keeping the gain. No? So in that position, there is no squint. That's why he has good vision with BSV in the BSV. Okay. So here either abduction or adduction limited or both. Palpebral fissure narrowing in adduction and widening in abduction. There can be retraction of the globe and upshoot or downshoot. So it's a case of Duane's retraction syndrome. Okay, now look at this child. I don't know, it's not that visible. Like appreciate, not appreciable. So this child is actually orthotropic in the primary gaze. But what did you see?
In the left lateral gaze, she has abduction deficit and adduction deficit in right gaze.
Abduction deficit is there, but adduction there was no deficit. No.
But there is a narrowing of palpebral fissure on
yes, narrowing
adduction.
of palpebral aperture is there. There is mild retraction also. So it's actually an orthotropic Duane's. Orthotropic Duane's with a type 1 orthotropic Duane's. Okay. So since the child is not having any head posture, nothing, so you can just leave this child. Don't have to do anything. Okay. So already told. Okay. Variable upshoot and downshoot, face turn to achieve binocularity. So there are some systemic associations with the Duane's retraction syndrome like golden hair, Wildervanck, etc. And these are the differential diagnoses. It means if someone asks about differential diagnosis, you can say sixth nerve palsy, infantile esotropia, Mobius syndrome. So I just wanted to ask, so if this child, what you can say in a sixth nerve palsy, the lateral, how much is the lateral rectus is not acting, according to that, that much ET will be there. But Duane's, if see, in this girl, she has almost -4 abduction deficit. Even then, she has no esotropia. So that's how that's the difference between Duane's retraction syndrome and a sixth nerve palsy. Sixth nerve palsy, according to the amount of lateral rectus weakness, you will get that much amount of esotropia. But Duane's, the amount, the lateral rectus movement may be very high, means restriction may be limitation may be very high, but even then you won't get that much of esotropia in Duane's. Okay. Treatment. So treatment as of any case, correct the refractive error, treatment of amblyopia. If no deviation in primary phase or no or minimal phase turn, you just observe. And if there is a primary position deviation and there is a significant head posture, cosmetically unacceptable globe retraction, upshoot and downshoot, you will take up the patient for surgery. But one thing you should know that you cannot fully correct the abduction. It will not come to normal. You can just should counsel the patient before we take up the patient for surgery. You can just improve the abduction, that's all. And if you have a severe upshoot and all, what you do is, this is something what you do, that is Y split. You split the lateral rectus muscles and recess also. Okay, it's for upshoots and all. LR split. Other than that, you do, if there is ESO, you do MR recession along with a vertical recti transposition. Superior rectus, you take it to the medial side, or inferior rectus, you take it to the middle. That I told you before. Now, like a NAPS procedure. So here,
what is the procedure for cosmetically unacceptable globe retraction?
That's what I've told. No, this is LR split with LR recession.
Same as upshoot and downshoot.
Yeah. And you have to see whether these your muscles are there is if your FDT shows MR contract means positive, you have to recess that MR also. Then otherwise it will not come. Means your retraction will not be reduced. So the retraction is basically because of your co-contraction, no? In here in Duane's retraction syndrome. So you have to recess the co-contracting muscle. Because when the child is looking, when the child is looking to the abducted, means wherever there is abduction deficit, what happens is LR is not functioning, but MR is co-contracting. It's along with LR, MR is also contracting. That's why you are getting retraction. So you have to recess that MR. Okay, and along with that, you should do a Y split. And if there is XODRS, like that, LR recession along with plus or minus Y split, depending upon what all additional features patient has. Okay.
Ma'am, what is VRT?
This is vertical recti transposition. Previously for NAPS, I have told, no, we keep the LR and MR to the SR side like this. Here, what you do is, here is ESO DRS, right? So what you do is, you take your superior rectus or inferior rectus towards your MR. Towards your LR, sorry, towards your LR, lateral rectus. Lateral rectus is not acting now, so you want to get the abduction more. So what you do is, you keep your superior rectus and inferior rectus towards the lateral rectus. You can do either a full tendon or a partial tendon, whatever you can do. Or only one SR, that also you can do. Okay. Got it?
Yes, ma'am. Thank you.
Okay. So I don't know whether I should continue. There are two, 3 slides about amblyopia. That's it. Okay. So there are amblyopia. It can be due to a strabismic amblyopia. This is more common in ESO deviation than in exo. Then anisometropic amblyopia, where you have a different means refractive error between the two eyes. Then refractive amblyopia, you have hyperopic amblyopia or astigmatism or myopia. Hyperopia more than 4.5. Astigmatism more than 2.5 and myopia more than 6. Then deprivational. Deprivational means eye means light is not entering the eye due to a congenital ptosis, cataract, or corneal opacity. This has the worst prognosis, and you can have toxic amblyopia in these types of drug toxicity, alcohol poisoning, alcohol, methanol poisoning, etc. And organic, actually, it's not amblyopia, organic pathologies and occlusion. Sometimes you give occlusion for amblyopia, you can have occlusion amblyopia of the occluded eye. Also is possible. And these are the refractive errors, how you should correct in each age group with and without squint. Means if the patient is having a hyperopia with esotropia, you have to give even with a plus 1.5. But if there is hyperopia without esotropia, you don't have to give. So there are some guidelines. This is the American Academy of Ophthalmology guideline. Sorry, this is the Indian guideline. There is one more, I think. Yeah. This is the Indian guidelines by the All India Ophthalmology. There is one more. This actually AO guidelines where this is more than -5. So I have that one. Just 1 minute. I'll take that. Hide. Okay. This is the American Academy of Ophthalmology guidelines. Each age which there's in India they have reduced the criteria even less. Okay, so that concludes my presentation. I hope something will be benefited from this.
Ma'am, one doubt. In FDT, should we do it in local or GA? Because
normally for adults you can do it in a topical anesthesia, but means better in a anesthetic setup, because sometimes oculocardiac reflex, if something happens, that will be a problem. And even for children, I do only under general anesthesia, because when we take up the patient for surgery just before that.
Okay, ma'am, I have one question. Actually, they are continuous asking, but we have a confusion. How much this resection or recession will correct the squint in the prism diopter? Like we are resecting.
Yeah, I normally LR, I think 3 diopter and MR 2.5 diopter, but all depends on your personal experience. If you keep on doing few mini surgeries, you will come to know how much it corrects for your patient, because sometimes the bite we may be taking will be different by different surgeon. No? So you have to take that value from your personal experience. But I think MR 2.5 and LR 3. I am not very sure. Yeah.
MR is a strong muscle, no ma'am. So it will give more.
What? Yeah, I may be ulta, I think. MR 3 and LR 2.5. But normal means usually we go, means we do surgery and we'll come to know, no? Means there is a table for this much amount of deviation, how much you should do. So once you keep do and you see your see your measurements for each case, and you will come to know what is sometimes it may undercorrect. Then you have to increase your recession. In that case, all depending on your cases.
Ma'am, I have a question.
Ask in the exam. Yeah, please. Faizan, please.
Oh, sorry, my question is unrelatable from this. My question is that if a patient has manifest deviation, exotropia or esotropia, so what is the significance of performing alternate cover test?
What? I didn't get it. Once more.
If a patient has manifest deviation, esotropia or exotropia, so what is the significance of doing alternate cover test?
No, you have to just see how, esotropia or esotropia, you need to know the latent deviation also, no?
Okay.
Yeah, means you for treating, you are not correcting only the tropia. You have to correct both the tropia as well as the phoria. Because otherwise the patient again will go for the once your fusion is interrupted, again the patient will go for tropia after some time. So you have to get the total amount of deviation. That's why you have to do alternating cover test.
Okay. Thank you, ma'am. Okay.
Ma'am, the occlusion, it is the same as we were taught, like, or something is changed about it, like the number of years is.
No, occlusion is normal occlusion patches, but there are amblyopia. There are many more there are recent advancements like in anisometropic amblyopia, there are something called the binocs, and there are revital. Then few other new things are there where you don't patch one eye, but you will reduce the contrast of the seeing eye, and you will and Yeah. So by adjusting the contrast of the image, you ask the patient to wear some glasses, and they will be doing some computer games. So in that, by adjusting the contrast of the image, you can treat the amblyopia. These are new things which came into.
Ma'am, you said binocs and something. So some perceptual learning method,
The
dioptic
perceptual
method.
learning, so many things are there.
So binocs is perceptual learning, ma'am. Okay.
Yeah, I'm not sure. I think it comes under that only. I'm not very sure. There are so many recent advances. I didn't means prepare that on much on that. But means normally for this visual deprivation amblyopia, the patching is the gold standard. But we have so many different means new things coming now, especially for anisometropic amblyopia. And another thing is that we cannot use these methods in a less than 4-year-old child, because child has to cooperate for these games. So in a small child, we cannot use there. You can do only patching. And also penalization. Atropine also you can give. The child is not at all means allowing for patching.
Ma'am, is there any role of that medicines levodopa, carbidopa? And
I have never used it. These all are just I have not used.
Thank you, Dr.
Textbook.
Remya. Yeah, you did great. Thank you.
ma'am.
Yeah,
Thank you,
I
ma'am.
think you must be exhausted by now. Okay. I think we can conclude the meeting because you've been talking for more than 2 hours now, Dr. Remya. Thank you so much. You covered everything. Yeah, your evaluation and the most common cases you might encounter in the exam. Dr. Kashif, do you have any? Yeah, you're welcome. Dr. Kashif, do you have any comments?
No, I think it was excellently prepared class because she had, Dr. Remya had so many cases from her own setup, and people who are not like people like me who are very much like don't know anything about screen. I also enjoyed the class. And most of the images were very clinical. Thank you.
Thank you, sir.
Thank you very much, ma'am. Immense help.
Welcome.
Thank you so much.
Thank you so much.
Thank you.
Thank you so much.
If you have any doubt, I can clear because I will try to clear.
Yes. Yes.
Thank you so
If there
much.
is any doubt, please post on the group so that we can, Dr. Remya or